Hello and welcome. My name's Andrew Wilson and welcome to the CCG Governing Body meeting for December. This, as always, is a meeting which is being held in public, not a public meeting. We do have public questions, and as we have been for some time now, a meeting is being held virtually because of COVID-19 restrictions. Just as a sort of a backdrop to the meeting, on a number of occasions when we've opened these meetings, we've discussed COVID-19, and it seems appropriate to do so again with the rise of the Omicron variant and with the work that's going into a very significant surge in the effort towards vaccination and boosters, well, vaccination in general, but boosters in particular. And I wanted to just say thank you to all those that are involved in that, all the people that are involved in vaccination sites, our member practices, those PCN directors. So I know we're doing a tremendous amount of additional work to get things up and running and to put an extra capacity. Our pharmacy colleagues are also putting an extra capacity, and of course hospital hubs which are being re-established to help the campaigners as well. And I know there will be many people in our health economy who, between now and Christmas and immediately after Christmas, and particularly this weekend, which is coming up, the last weekend before Christmas, who will be given up time to vaccinate. So thank you to all of those people. In particular, thank you to the volunteers. And we've said this before on these calls, but some of the volunteers that are still volunteering in the vaccination centres have been volunteering every single week since the vaccination started, which was a year ago. So a huge thank you to those people who have done that throughout the cold and rain, the summer, and back to the cold and rain. It's enormously appreciated, and other people who want to come forward and volunteer, that's also extraordinarily welcome. Lastly, a thank you to the public around the vaccination campaign, because people are coming forward in their droves, which is great to be vaccinated, and we can't have a vaccination campaign unless people come up and give us their arm, and this campaign is important. So thank you to members of the public for coming forward. So once again, I'm afraid, colleagues, the backdrop to our meeting is COVID-19. I don't think that's going to change in the immediate future, but I think it's important that we recognise all those that have been involved. And the last thing I'll say is to the CCG staff, who many of whom have been redeployed back to vaccinations from their CCG duties. I'm sure we'll do that with enthusiasm and gusto, as they have done previously. So that's in way of a welcome and context. We have apologies, I believe, from, no, we don't have any apologies. Christine, have we got any apologies that have come in recently? I'll take silence as a no, unless you want to speak.
Yes, we have apologies from Ian Ashworth and Matt Tyra.
Okay, thank you very much, Christine. So those are noted. I do know that we are correct. That takes us then to declarations of interest. As always, colleagues have a written declaration of interest, which is on the CCG website. This is an opportunity to add anything to that, amend that, or to point out anything in particular which is relevant to today's agenda. Does anybody wish to make an additional declaration of interest? No? Okay, thank you. That takes us then to the minutes of our previous meetings, which we have 3 sets of. So our meetings from the 21st, well, actually, before we start this, actually, there are some errors that we've already noticed. So we have on page 3, we've got an incorrectly titled, said 16th of September, and it should say 21st of October. Section 6.1 incorrectly refers to the next meeting as the 11th of October, and it should say 11th of November. And section 4.2, there's a typo when it says Matthew Cunning instead of Matthew Cunningham. So thank you to Peter for those pre-notified corrections. So people, if you're going to say those ones, cross those off your list. But otherwise, let's go to the meeting on the 21st of October, which is on starts on page 3 of your pack. Is there anything on page 3 or 4, 5, 6, 7, 8, or 9 of that pack? No. thank you very much. We'll take those as a true record. And then we go to the governing body meeting of the 11th of November, which is the first of our extraordinary governing body meetings. And those are on page 10 of your pack. So on page 10, on page 11, 12 or 13. No corrections on those. So then we go to the 18th, another extraordinary governing body, 18th of November, which is on page 14 of your pack. Page 14, 15, 16 or 17. Nope, thank you very much. So we'll take all of those minutes as agreed then. Thank you very much. That takes us then to the next item, which is any matters arising from those minutes. Nothing to raise. There is no action log. There are no actions to be addressed. So thank you very much. So that's that section completed. We haven't done introductions. Your names are on the screens, and if I can ask, as always, if colleagues could introduce themselves the first time they speak, and with their name and their position on the governing body. And if we then go to patient and public focus, so this is the public questions. I understand we don't have any public questions on today's agenda, but we do have a patient story, which we're hoping to be able to show on video, and which is relevant to our further agenda. So I think Emma is going to attempt to play the video for us. So could we have that video, please, Emma?
Hello, my name's Darren Weaver and I'm the mother of Jason Daniel Weaver. Emma Merwold looks after him through CHC, and I'd just like to really pass on my thanks to the service for the help it's given to Jay. It can be very lonely being disabled. Jay was diagnosed with Duchenne when he was 10. He'd already had lots of problems before then. By 13 he couldn't walk. He didn't go to uni. Well, he tried. We did 1 year. He has very few friends as a result. He became very depressed last year after being groomed by somebody, well, groomed, but somebody who financially and emotionally ripped him off on the internet. And he tried to take his own life last year. So with Emma's help, we've put a care team into place so that he doesn't rely on me and my husband, because we're both heading quickly towards 60. And we're next stage is for us to look for somewhere for Jay to have an independent life, with a lot of safeguarding around it, because he has he can either be very trusting or he doesn't trust you at all, black or white, and that's part of Jay. You have to know him, but he would, if he liked you, he'd give you everything he had, and he has done this to people in the past. So the service is vital for people like me and Jay and Jay's dad, because it gets so lonely, you get so tired, and you feel like you're on your own with it. And what happens when we're not here, and we want a life too, and all these things. So you need people to help fight for you, because sometimes you just can't fight any longer. You can't. You don't have it within you. And as I say, it's very lonely and very isolating for the whole family, because all our lives are strange, and there's a lot of guilt. And Jay feels guilty. We feel guilty. But you say you need somebody outside the family to chivvy things along and do the things sometimes when you just haven't got the steam. So that's why it's important that families like us have the support of people who understand our needs and are willing to fight for us. Thank you.
Thank you very much for that. And I think it is particularly relevant because we have got a section, we've got a decision to be made around CHC later in our agenda. I think that's really helpful, isn't it? We often talk about CHC. When we talk about it, we normally talk about a budget and we talk about savings. I think that's really helpful to have somebody in mind, and perhaps that will be Jay when we discuss it later, that this is a service that is provided to people, that is a frontline clinical service, and that is a different perspective on it. I think that's really helpful to have that context. Does anybody wish to comment? Gwyd, did you want to comment on the video?
Just briefly on what you were saying, I think the message there about you need people to fight for you is really apt, and I think we have to remember there's a person at the end of every contact change or every decision that we make. So no, I think that was a wonderful message that she gave. Thank you.
So thank you much, and thank you very much for all the people involved in that video. Sharing those stories can sometimes be difficult, so thank you for the family for doing that for us. It's very helpful. Right, thank you. So that's great context. That takes us on to our next item, which is 3.2, which is our accountable officers report. So Claire, can you take that for us, please?
I can, thank you. So as usual, this highlights items that aren't covered elsewhere in the governing body papers. I think, so I mean, Andrew started with COVID, and we seem to have started most of our meetings for the past year and a half with that, and reflecting that Cheshire CCG, I think, will have been a virtual organisation from start to finish by going to lockdown last March 2020. By the time we're disestablished in March 2022, that would be 2 years that we've worked as a virtual organisation. So I think it's been challenging, but absolutely, amazing performance from everybody. So thank you for that. So in the report, you can see there are, there's updates on COVID. I just wanted to sort of give you probably a more up-to-date update. When these papers are written, the world is moving so quickly, particularly with COVID. So you can see the information in here, and who would have thought, a year ago, we were vaccinating Mona Thomas, and 12+ months on, we are now in the booster phase of that campaign. So to date, we have delivered over 1.3 million vaccinations for our population in Cheshire, and we've actually already delivered 300,000 plus booster vaccinations in terms of keeping everybody safe. So obviously the booster campaign at the moment, we will have all heard the Prime Minister over the weekend. So a real challenge for all of us. But I think we have risen to that challenge, and a massive thank you to Matthew, who's sort of taken on the exec lead role for the campaign now that Tracy's left, but also to Adam McClure, Chris Amory and Chris Lees in terms of coordination, leadership and sort of comms, primary care and the overall programme. So really big thank you, because I know it's been an enormous amount of work over the past, well, just weeks really. So by next week, we will have doubled our capacity for the flu, the COVID booster vaccination. That includes a walk-in at the Cathedral. We've got the Hospital Hub Plus at Churton House, moving to Huntington in Cheshire West, setting up more community pharmacies, our primary care networks coming back on board that hadn't been, that sort of taken some time out, and extending the opening hours. So by next week, we'll have doubled our capacity, but the challenge is still there. We still have over 200,000 of our population to deliver the booster vaccine to, ideally by the end of the calendar year. But I think that's going to be a challenge, but we are working incredibly hard with all of our partners. And you probably will have seen both in the news, and you'll know in terms of the military are now supporting at the Cathedral. So we've got the military, we've got St John's Ambulance, we've got Cheshire Fire Service working with us to deliver this programme with all of our other partners. We will be sending a letter out later today, thanking staff for all the work, but as Andrew said, asking them to consider about how we repurpose some of our staff to support the vaccine programme. So the letter will go to staff, obviously including our clinical leads, and to governing body members. So I'd ask that you consider how you can support the vaccine booster programme, both clinically and with some admin and project support. I think it's really important that we all repurpose, because we want to get people vaccinated as quickly as possible. And obviously we want to protect our wider population, and that includes the urgent care agenda. So Neil and his team are ably leading that, but it is another challenge for us all. I think just with this, we also need to think about the flu campaign, and making sure that we promote and protect ourselves from flu as well, because obviously that will give people additional protection. So lots and lots on COVID, as you would imagine, from me in this report, but just to say thank you, but very happy myself and others, and Andy and Sinead are here and they can answer any sort of the clinical questions, but some really positive work over the past few weeks, and thank you to everybody. You can see in the report here, just in a very small section on transition to the Integrated Care Board, and attached are 2 appendices, one which gives everybody assurance in terms of our close down and transition work, which is really important in terms of the safe transfer of staff and responsibilities to the Integrated Care Board as a successor organisation, but then some details about what we're doing in Cheshire and Merseyside for consistency and clarity in terms of the sender and the receiver organisation. So hopefully those appendices give you information for a start, but also provide assurance that we're moving ahead successfully and doing all we can. I just wanted to give you a bit more of an update, if that's okay, on Cheshire and Merseyside and Place. So Graham Irwin's been appointed as the Chief Exec Designate of Cheshire and Merseyside ICB. He'll start formally the statutory post in April, but he's been appointed and started on the 1st of December. And I think that's really helpful in terms of bringing some stability and clarity to Cheshire and Merseyside. Clearly, we've had interims, and Sheena Comiskey has done a fantastic job as the interim over the past 2 or 3 months, and has now returned to Cheshire and Rural Partnership. Graham did a briefing to staff on Tuesday, and I just noted down some of his key priorities, which I think are important for the governing body. So in terms of, I guess, 4 priorities for the Chief Exec of the ICB were delivery today, so very much about the vaccine programme, moving on with that, meeting the national requirements and challenges, but also the urgent care agenda, discharging patients safely and appropriately, and that's about system working, but very much about the here and now in terms of how we work together. Then the second one was about recovery from the pandemic. He said in Cheshire and Merseyside, over 1,000 people are now waiting 104 weeks for treatment. And clearly, 52 weeks used to be the common sort of vocabulary. It's now moved to 104 weeks. So that's not 1,000 in Cheshire. That is across Cheshire and Merseyside. I just want to be absolutely clear that. But this is very much about elective recovery. And Sinead is doing some work at Cheshire and Merseyside for us. So again, we can talk about that, but it's very much about moving back to the norm. Talked about obviously integrated services and how much we spend on NHS services and how we want to reprofile some of that funding into other services, and obviously what we're doing in Place is a really good example of that. And then obviously a focus on the future in terms of health inequalities and the wider determinants, and what the opportunities of a truly integrated Cheshire and Merseyside are. I think it was really important to hear that from him, for all of the staff to be invited to that. So a few more things. So in terms of establishing the Integrated Care Board, obviously consultation for the constitution has ended. Work is continuing on that, and we'll probably hear more about that in the new year. A working group has been set up to establish the Integrated Care Partnership, to be known as the Healthcare Partnership. Because under the Integrated Care system, there's the Integrated Care Board and there's the Integrated Care Partnership. So work is going on that. Andrew continues to chair the Joint Committee of Cheshire and Merseyside CCGs, and we obviously at the last meeting agreed devolved increased delegation and authority up to Cheshire and Merseyside Joint Committee, and there are 3 subcommittees underneath: quality, performance and finance, and they've met this month. Obviously we've got the 2 provider collaboratives within the ICS, and we can talk about that at a future meeting. We'll get people who are leading those systems to come and talk to us. Consultation has now ended for board level posts, board level people within the CCG, and executive director posts for the statutory roles, which is medical director, director of nursing and care, and finance director, are currently in recruitment at the moment. There's going to be further discussions around other posts in the coming weeks. I think yesterday and today, the appointments for and recruitment for the non-exec directors for the ICB have been taking place, and the chair recruitment. Obviously, David Flory has been acting across from Cumbria and South Lancs for a while. but the recruitment for the substantive chair starts this week. So lots and lots going on, and I think we are playing our part as Cheshire CCG in terms of leadership, in terms of advice, and the development of Cheshire and Merseyside. But obviously the focus has to be for us place. So there are various discussions going on with partner organisations in the two places, and we met last week with David Florey and Graham Owen to update on plans and developments, and we're working through the governance at the moment, because obviously we want as much delegated into place as possible from the ICB. So I think really good progress. It is incredibly busy, and we're doing this in parallel to business as usual and the vaccine programme. So I know, there's some people involved and it's really difficult to keep people up to speed. So I hope that was helpful in terms of an update. I could talk forever on this, but it is really, the really key streams of work to transition Cheshire CCG into Cheshire and Merseyside ICB, but also to just support the development of the place. Just moving on, you can see there the Cheshire East sensory impairment strategy. We recommend that to the governing body from an exec team. To the suspension of intrapartum care at Maxfield General, this continues. We've reported on this over the past 2 years, 18 months really, and the trust, due to safety issues, is still having to suspend that service, but obviously ladies in Macclesfield can go to neighbouring providers for their maternity services, and they can still have home births and all those sort of antenatal care at Macclesfield, which is really important. The CCG are working with Cheshire West and Chester on our care home commissioning framework. I think this is just another good example of joint working and how we can protect our vulnerable residents in the future by working together, and obviously by being part of that framework, it gives us better value in terms of quality and efficiency going forward. Just want to touch on section 8, if that's okay, in terms of the CCG workforce. You can see here that we've had some turnover, which I don't think is particularly surprising. It's gone up a little bit from October's, from September's. I mean, in a time of change, there's always churn in terms of staff, and I think it's just to be aware of that. But you can also see from October to September, the days lost to sickness has gone down quite a lot, which is really positive, but that the actual days lost in terms of stress, anxiety and depression has gone up. That's something we're really conscious about, and obviously from an exec team and with Chris's support, Chris Morris' support, looking at all of our wellbeing options for staff. I mean, if you think about, we've had sort of change fatigue from the reorganisation of the 4 CCGs into one, lockdown, virtual working, and then future changes from CCG into the ICB, on top of the amount of work our staff are doing. We really need to focus on our staff's wellbeing, and so it's really important message from the exec team, working with all of our respective sort of senior leaders, that we focus on our staff, and it's really important, particularly at this time, that people take a break over Christmas. Despite how busy it is, we are really recommending that staff take some time off over Christmas, and that isn't just CCG staff. We know this is right across the system, but it's something I really want to focus on in the next last 3-4 months of the CCG's lifetime. And then just finally, you can see there in terms of the workforce race equality standard action plan, that's now being considered by the exec team and approved for publication. So quite a lot in there, Andrew, and I haven't gone through everything. Obviously happy to answer questions on things, but I just wanted to focus particularly on COVID, on the changes in Cheshire and Merseyside, and then our staff wellbeing. Thank you.
Thank you for Claire. It's very, very informative. Gwyd does want to come in with a question.
Thank you, Andrew. Gwyd and Rees, Deputy Chair. Thanks, Claire. Firstly, thank you very, very much. I know lots of people have been working incredibly hard for a long time now on the vaccination programme. I just really want to make sure we're focused. The WHO talks about the unprecedented surge in Omicron, and there's a danger that with fatigue and complacency, we don't necessarily realise that things could get very bad again. I think you mentioned 200,000 as a target to vaccinate before the end of the calendar year. And I suppose what I'm asking is, are we confident that we are maximising every collaborative opportunity and that we are turning every stone over and using all available resources, and that we're brave, that we're flexible, and that we're actually making sure that we will hit that target, and that we appropriately take risks, you know, such as the relaxation of the 15-minute observation period, because I worry that those that are most disadvantaged in our population won't necessarily get the access to vaccines that they need. It's not a criticism at all. I think what we've achieved is wonderful. I suppose I'm just asking us for us to be insatiable, you know, and to really want to keep going. Thank you.
Thanks, Gwydion. All I can say is we are trying our hardest. It's a collective we. You know, the partnership effort is phenomenal, and public engagement and public spirit and support. And Andrew mentioned volunteers at the beginning. So, you know, it is an incredibly challenging target. As I said, you know, we will have doubled our capacity by next week in terms of longer opening hours, more primary care networks coming back on board, community pharmacists. We've got the walk-in centres. We still have the roving model, which goes into the underserved communities, and we'll look at every option. You know, it is about staff capacity to support some of these in terms of vaccinators. We will repurpose our staff. The local authorities are going to repurpose some of theirs. You know, we'll do everything we can. We will be out supporting primary care networks, community pharmacists. You know, we'll do whatever we can to achieve this target, but it is an enormous challenge, and I think we have to recognise that. We also, in terms of our communication, engagement, empowerment, we need to encourage the population to come forward. Chester Cathedral Walk-in Centre opened yesterday at 10:15, and by about 11 o'clock there were queues, which is incredibly positive. Make sure the models of delivery meet the needs and demands of the population. But then other sites, there were sort of 80% vacancies in terms of booking. So we need to make sure, you know, if we have walk-in centres, people will come because it fits with people's lifestyles. So we have to, if necessary, change and flex. Might not be ideal or particularly convenient for us, but if we have to set up new sites, new walk-in centres, we will, to make sure we get out there and meet, you know, because in a way we have to take the vaccine to the population, not expect the population to come to where it's convenient for those providing it. So I suppose in summary, we're doing everything we can. We will be as flexible and as brave as we can be. Clearly the 15-minute Pfizer change has helped and will help enormously in terms of capacity and potentially lanes of people to vaccinate. But you know, any ideas, any support, gladly welcomed. I think our comms team are doing a fantastic job with partners, but we just need to keep getting the message out. Please come for your vaccination first, second, booster. I'll put flu in there as well, just as a to promote that. So thank you.
Thank you. Leslie, I suspect yours might be on vaccination, I'm just guessing, but you want to come in?
Yes. Leslie Appleton, Governing Body GP. Just Claire's answered part of my question really was around communication, really the importance of trying to get the message out for people to come forward for their vaccine. I think it's also being clear about what is on offer, whether they need to book an appointment or they can just turn up. I think there's been some confusion sort of locally in the community about what, because I think there's so much on offer, which is fantastic. It's where can I go and how can I access this? And I think sometimes they're told, you know, on the websites they're directed to their GP, and you know, the information sort of needs to be clearer, I think, for them. But I think everything's being done, and I think it's a fantastic effort, and we're all, I suppose, pulling our socks up and get sort of doing additional clinics and things over Christmas. So we're all in it together. I think that's the important thing. Thanks.
Thank you. Can I just remind colleagues, if they're not speaking, just make sure their microphones are off, because we are getting a bit of feedback. Whether it's microphones, I don't know, but if we can try that, might be helpful. Right, can I bring in Chris Morris, please? I think Peter's made a comment about the sensory impairment strategy, but Chris is going to bring it up as well. So Chris, do you want to come in, please?
Yeah, thank you. Thanks, Claire. Chris Morris, registered nurse. I think just to make a comment around sensory impairment strategy. I think it's a really nicely written strategy, and it's really good to see the level of engagement that's taken place in pulling that together. I guess, as you know, strategies can often sit on a shelf and gather dust. So for me, it's about how can we ensure that successor organisations and the place committees actively monitor the impact that that strategy is going to have on that sector of our population.
Thanks, Christine. No, that was exactly the conversation we had at execs, both in terms of the quality of the document and the work that had gone in. But you're right, this is very much a place strategy, and it needs to be, it needs to have given the importance that it needs. And I think the place committee is absolutely the right, when I say place, the right forum, the right meeting to take that forward. And I think in an ideal world, we would have taken this to our next CCG place committee. We wanted to get it through governing body because the execs had supported it. But you're right, when we're moving forward, and I guess this is part of the appendix in terms of our close down and transition, we need to think, and we're doing this work in terms of what documents, what business is flowing through our respective committees. Obviously, it's gone up to Cheshire and Merseyside, but how does that flow into place? And making sure we don't lose and forget anything. But I think the work that Natalie's leading in terms of that close down transition, I know Peter and Pam are involved in that as well, I think will give us that assurance, but we do need to make sure we pick up these sort of documents. So yeah, thank you.
Are there any further questions for Claire on the Accountable Officer's report? I don't believe so.
Thank you.
No, we're asked to do two things, which is to note the report. We're also asked to approve the East Sensory Impairment Strategy for 21-24. Are we happy to do both of those things? I've interpreted faces of agreement. Lovely, thank you. Thank you very much for that, Claire. Those of you who were eagle-eyed will realise that I missed off section 3.1, which is the Chair's report. It wasn't deliberate, but now that I go back to it, most of what I was going to say has either been picked up by Claire or is on future agenda items. I was simply going to mention the developments that are happening in borough places at Cheshire East and Cheshire West, and how actually it's been positive developments that is moving forward at pace in both the borough places in terms of strategy and structure and governance. So that's all going well, and I think we'll continue to gain speed and momentum. Within place, of course, we've got our two place committees. We've had each of those two place committees. Now there are reports later on the agenda from the place committees, and my thanks to Gwydion Rees, who chaired the Cheshire West one in my absence because I was on leave and had COVID. So thank you for that, Gwyd. But both of those have gone went well, I think. And then at Cheshire and Mersey level, of course, we have had now we continue to have the joint committee, but the joint committee has now got considerably more delegation to it. All of the governing bodies in Cheshire and Merseyside have given it substantial delegation, and it has met on one occasion to receive those delegations. The meeting this month we have deferred because the vaccination programme will pick it up in January. And there are subcommittees of the joint committee. Two of those have met. Two of the three of those have met as well. I understand that those were successful meetings as well. So, but there is more on that later in the agenda, and most of the details Claire has already picked up on. So I'll pause in case there are any questions for me on the Chair's report. And if not, I'll simply move on then. That's just for information and noting. So that moves on to section 4.1, which is on page 39 of your pack, and is the financial plan, H2 of 21-22. So Linda, please.
Hi there. So first off, I'd like to apologise for the title on the agenda, with the financial period's been stated as H2. obviously everybody hopefully now knows that this is the second 6 months of the year, or the 6-month period to the end of March 2022. So many apologies, it wasn't described that way. So I don't know how that happened, slight hiccup. So the paper in the government body pack explains the approach to and the final budget for the last 6 months of the year. It's consistent with the previous discussions we've had in the private committee last month, and is the final submission to the healthcare partnership, which happened on the 11th of November. So hopefully you will recognise what is within here from our previous discussions. Specifically points to note, there are 3 pots of money. There's the major CCG budget, which is the 634 million. But then we have 2 other pots, which is the service development and spending review monies, and then also an additional system funding. This gives us an overall resource of 652 million. However, the planned expenditure is 659 million. So this gives us a shortfall of approximately 7 million. This is a 3.5% financial gap based on non-NHS expenditure, and all of the CCGs in Cheshire and Merseyside have the same challenge. And as you'll know, we are working together, as we did in the first 6 months, to get to a consistent challenge, a consistent approach to covering the gap, and that we are working together across all of the CCGs to do this. So in order to do this, the CCGs are in the process of producing plans to cover their gaps, and this will be taken to the Joint Finance Committee of the Joint CCG Committee for agreement in January 2022. They will also be monitored by this committee, as will all of our financial performance going forward. The first month end report will be taken to the Joint Finance Committee in January and will be the November 2021 position. So locally, however, just so that we keep an eye on this, we will still be producing detailed financial reports, and those will be going to the exec team, and they will also be going out to the governing body and specifically to the members of the previous Finance Committee for information only. The budget for the 6 months to the end of March 22 is included in Appendix 1, and as you'll be aware, this supersedes then the interim budget, which was agreed in October 2021. So basically, the ask of this paper is that you agree the budget for H2, the 6 months to the end of the 31st of March 2022, which is in line with that which has been submitted nationally. Thank you.
Thank you, Linda. Colleagues, we have been asked to approve this budget, so I'm quite confident there will be questions for Linda. We start off with Suzanne, please. So Suzanne, do you want to come in, please?
Thank you, Suzanne Horrell, lay member for governance. I just had a query on the additional 1.6 million that we've already sort of baked into the plan, efficiency savings, whether that is on target, where we are with that to date.
Yeah, as far as I'm aware, we are on target to deliver that.
Okay, thank you.
Thank you very much. Then Fiona, and then following that, Peter.
Hi.
Oh, Fiona, you're
Oh, is that better? It's Dr. McGregor Smith. I'm a GP on the board and a GP in Northwich. So I've got 3 queries. One was the if we don't identify the unidentified efficiency savings, what happens to that? Second was, I'm sure there will be more cost expenditure involved in what's happening now with the booster programme. Will that be covered at a national level as opposed to by us? And the third one maybe is a bit more specific, which is when I looked at the planned expenditure, I was interested to see, is on page 47, the delegated primary care, the percentage, which is nearly 40%, of general practice expenditure that goes to PMS rather than GMS. I thought quite a lot of our PMS practices had been superseded, and that had all kind of been absorbed into what's going to be PCN expenditure going forward. So I might have completely got that wrong, but that seemed a high percentage of our practices who are PMS.
And will that impact, I suppose, on what we send next, going from April 22 on, what they need to pick up?
Okay, in terms of the unidentified savings, well, we're going to put an initial plan together, which hopefully we will then be able to meet. Where we haven't been able to do that, we will be in discussions with all of the CCGs and also the provider trusts across Cheshire and Merseyside, because we all have to get over the line together. We have to deliver a balanced budget across all of the organisations in Cheshire and Merseyside. So that is what we will be doing. And if we fall short of our plans, we will hope that others exceed their plans and that we come to a balanced budget together. That's what we did in the first 6 months of the year, so hopefully we will be able to do that again. Because all of the monitoring is now at a Cheshire and Merseyside level for the CCGs through the Joint Committee, there is also other committees within Cheshire and Merseyside as a whole that are monitoring the whole financial position for all of the 18 organisations within Cheshire and Merseyside. So they will be working and we will all be working together to get to a balanced position. So hopefully that's that one. In terms of the vaccines, yes, that will be nationally funded. So that's fine. That won't create an additional pressure for us. It will create an additional pressure for the government and the Treasury. And in terms of the PMS budgets, we do have a PMS. I'm sure Neil is probably a bit more closer to which ones they are, but we have a number of APMS which come under this, which are delivered by other providers such as Cheshire and Wirral Partnership Trust.
Yeah, do you want me to just come in? The other thing to note there is there's a significant number of our practices who are still on a PMS contract. What was written out of the National Contracting in Primary Care was the premiums associated with that contract. So when that happened, practices were given the option of either staying on a PMS contract without a premium or moving across to GMS, and many of them said we'll just stay on the historical contract form, but they get no premium. So in effect, the terms and conditions financially are exactly the same as GMS. It's just the contract form we use, which explains why the number looks higher than you would expect, Fiona.
Thank you.
Thank you, Mary, for those. Can I go to Peter, please?
Yes, thank you very much, Dr. Wilson. I want to build on the last two questions, really, and just go back to the previous decisions that we've taken. I think at the last governing body meeting, we would effectively have committed ourselves to achieving a balanced position as a CCG. We're still accountable and responsible for that. We're not, as a governing body, we're not accountable and responsible for the system target. So if somebody elsewhere overachieves, we can't underachieve because we've made that commitment. Now, looking at that overall 8.7 million mentioned in section 2.9, we've got 7.1 million unidentified and 1.6 billion identified, which Linda's assured Suzanne that we're on track to achieve. I would, first of all, I'd be very interested in having, for the last 3 months of the year, an elemental breakdown of what's happening with that target coming back to the governing body, and not just for information, because it may well be that we have to take action on our own behalf to actually achieve that target. So I suppose the question is, how will we be informed as to our progress against that 8.7 million?
So in terms of that, obviously, I do intend to do the governing body. Well, actually, we're going to produce the Finance Committee detailed report, and we can also send a summary level round to everyone so everyone can see the progress. It is being monitored through the Joint Committee structure now, so it is being monitored that way, and it will also be monitored at the meetings where they do the trusts and the CCGs together. I am aware that we will need to meet our balanced budget, and the way in which that happened in the first 6 months, and I envisage it happening in the second 6 months, will be for the system monies to be altered to allow us to receive more or less money depending on our success around achieving the quick plan. In terms of, so the process about how that's going to be done is going to be taken to the January meeting of the Joint Finance Committee, so that we will have a process across the CCGs to understand everybody's position as we go through, to how we agree that position, how we then transfer the money around. So there will be a process which will go to the Joint Committee in January on how this will then work. Also, we do have a member of the governing body who sits on that Joint Finance Committee, because Dr. Gwydion Rees sits on our Joint Finance Committee as well. So he will be your eye in the sky to see what's going on across the Cheshire Merseyside CCGs.
Could I just come back there very quickly, Dr. Wilson? My understanding from that is that our allocation may be changed as we move through the last 3 months of the year. Okay, thank you.
Thank you very much. Are there any further questions for Linda on that? We have now got a bit of a complex maelstrom of governance, haven't we, in terms of the joint committees and the place committees and our governing body. But I think we, having delegated to the joint committee, having that structure and having a finance committee reporting into the joint committee, that is where hopefully we will get the majority of our assurance that our responsibilities are still being effectively undertaken, albeit collectively by the Cheshire and Merseyside CCGs rather than just us for the next few months. But yes, you're quite right, Peter, we remain accountable for our delivery. Right, thank you very much. We are asked on page 39 to approve the budget for the second half of 21-22 as is outlined in the paper. Is anybody feeling that we should not do that? Okay, I take it then that we are in agreement and that we will approve it. Yep, thank you. That's what you're agreeing. Thank you very much, Linda. Thank you for that.
Thank you.
That moves us on to 4.2, which is the paper that we mentioned earlier when we had the patient story, which is the CHC performance and service delivery, which is on page 49 of your pack. I think Paula is going to open, but probably pass on to Karen fairly quickly. So Paula.
Thank you, Chair. Yes, Paula Webb, Director of Quality, Patient Experience and Safeguarding. I'm supported today by Karen Smith, who is Deputy Director of our Cheshire Continuing Healthcare Service. And also as well, just to highlight that Andy McCallavy is our governing body clinical lead sponsor for this paper. And we also have Andrew Whittingham here with us today. He's one of our senior finance staff to support us with any questions we may have around finance. You have a detailed paper before you, which has got 3 asks from a governing body. There is information in there about performance and delivery and capacity, and we'd ask that people understand that, because that is actually the nub of this paper and is key to understanding why there's a recommendation here before you today. And that people then understand the gaps that we currently have in terms of trying to deliver the standard of service that we need to, and we want to, and we aspire to. And then there's also a request for people to endorse the recommendation that we have made. Before I hand over to Karen, I do want to emphasise that the decision that we're being asked today to make is about a frontline clinical service. We've heard today about the changes that our CHC service make to lives. And the flip side to that is that we need to be adequately resourced to do it. And if we don't have the right resources to do that, we risk not being able to change lives as quickly as we would like to. And the nub of this is having enough staff to assess people, source packages of care, and just as importantly, to then review those, so that actually people continue to get the right care that they need. And linking to a thread earlier in Claire's paper, the criticality of this service to support flow through our system cannot be understated. We do have a situation whereby we have people who need admissions to hospital, and that is right and proper to do so. But we also have situations as well where with timely intervention, inputs and reviews from our CHC service, we can try and reduce either the need for admission or the time in which people spend in hospital. And then the other aspect of this is once people are in hospital, it's a vital service to support discharges, either for people to go home or back to a care setting where they can receive the appropriate care. So I'll pause there and hand over to Karen. Thank you.
Thank you, Paula, very much. Good morning, everyone. My name is Karen Smith. I'm the Deputy Director of Continuing Healthcare Services for Cheshire CCG. I'm presuming that everyone's read the paper, so I'll just provide you with a summary and then I'll be happy to take any questions that anybody has. So Cheshire Continuing Healthcare Service is a large service. As you know, we have a population in Cheshire of around 800,000 people, and we cover a third of the Cheshire Merseyside footprint. The current caseload is 3,800 individuals, and every child, young person and adult eligible for NHS Continuing Healthcare or Section 117 Aftercare has a named case manager. So as you heard from Di Weaver in the patient story, she and Jay know who Jay's case manager is. Cheshire CCG currently spend around £110 million annually on CHC services, and just over 3% of that, around 3.45 million of that, is spent on staffing costs. The paper talks through legislation that tells us what the service must deliver, and I hope that the paper shows you that we're a forward-thinking service that's efficient and that we've done all we can to ensure robust policies and processes are in place. We've also digitalised significant sections of the patient pathway and are well respected by NHS England Strategic Improvement Programme colleagues, amongst others. We know that a move to integrated care system is imminent, and so since April 2020 we've been developing an operating model that delivers in the two places of East and West Cheshire, and we've also identified functions of the service where economies of scale make sense to deliver across the two places as Pan Cheshire. We're integral to the Cheshire and Merseyside Transition Steering Group, and we've confirmed with the Senior Responsible Officer leading that work that place-based working and delivery of face-to-face services in line with legislation will continue in an ICS, that the frameworks aren't changing and the work that we do on the ground will continue. In 2019, we were delivering as a service against all of NHS England's key performance indicators, and the last consideration of any staffing levels and demand was completed in 2017. Since that time, unfortunately, the world has changed. Demand has increased. Hospital discharge processes are significantly different, as Paula alluded to, and will remain so. And this has impacted on the service, as the majority of our referrals are a result from people being discharged from hospital with either new or increased needs. Working virtually has also brought new challenges, and each interaction with people now takes more time. We need to support our public through using new systems as well as our staff. Challenges in the provider market has also meant that more resources required. Where once we could approach one provider to commission a package of care for a patient, we now find that we need 2 and up to 4 providers to ensure that a safe package of care can be jigsawed together to provide care for that one person. And we're also seeing increased safeguarding concerns raised in relation to providers which require an urgent response from our staff. Rightly, we also continuously improve the quality of services because of learning from national incidents, publications, scrutiny from regulators, or from feedback from our service users. We have managed to absorb much of this additional workload, but we can't do any more now without additional resource, which is why I'm here today to make this ask of you. Capacity modelling in October this year showed that we have a resource gap of 15.4 clinical staff and 10.7 administrative staff. And the cost of providing this is £1,073,421. Administrators, as part of that picture, are essential in arranging the many assessments and reviews, as well as performing multiple back office functions that record the activity that the service delivers and also make sure that providers get paid. We work closely with our finance colleagues in relation to invoicing and systems, and administrators play a huge part in that. It also ensures that clinical time can be used to deliver clinical activity. The gap in the service identified results in significant risks to patient safety, patient experience, staff experience, the CCG reputation and efficient use of the cost of care budget, and these are described in the paper. However, providing the additional resource actually provides opportunities to return this investment, as well as to assure ourselves that patients are safe and receiving appropriate care. And completing reviews on time and assessments on time is estimated to return approximately £2.46 million on the basis of this investment. So there are 4 options described in the paper, and we know that nationally recruitment and retention of staff is challenging at the moment, and partly because of this and also the imminent move to an integrated care system, option 4 is recommended. So this asks to resource the service up to the proposed number of staff with review points using a phased approach. This allows us to consider the system-wide recovery, the impact of the investment on progress towards meeting performance indicators, and success in stabilising workforce. It will also help mitigate the risk of failure to recruit and ability to train new staff and new starters as they come on board. So I hope the paper ensures you that the ask for significant investment is realistic and that the service is committed to do all we can to make efficient use of the budget and to continue to improve the quality of the service required that is provided to the population of Cheshire. And as Paula has said, there are a number of asks in the paper, but the governing body overall is asked to make a decision to endorse option 4 today. And I'll happily take any questions. Thank you.
Thank you very much, Karen, and thank you for the paper, which is very helpful. We do have some questions. Can I start with Gwydion, please?
Hi, Gwydion Rees, Governing Body GP. Thank you, Karen. A really detailed paper, and I'm sorry if I've misunderstood it. I think the work is obviously extremely important. It ties in nicely with our patient message and us needing to fight for them. Just want to ask a quick question on table 2, page 17. So I don't doubt at all that the service is under-resourced. Could you just comment on, in one of the rows, it talks about number of incomplete assessments exceeding 26 weeks. I think you've got 5, and then number exceeding 12 weeks, 8, and then obviously in the shorter timescales, longer. Are you appropriately moving available and suitable resource to getting rid of those long waits? You know, I expect that you are, because I accept that you need more funding, but I'd just be very keen to get some clarity on who are these people who are waiting so long and why are they waiting so long, please?
Thank you, Gwydion. Yes, we are prioritising work to make sure that the people waiting the longest are assessed and dealt with first. That number has steadily come down since the end of the pandemic and the return to business as usual work. I think it's in real time today. I think it's down even further. I think we have now got 9 people waiting, and my understanding is that they are all booked in bar 1, and that's because of exceptional circumstances related to the patient's needs rather than a staffing need. But yes, they are being prioritised and booked in already.
Thank you very much. Great question. Gwydion, can I bring in Pam, please?
Yeah, thank you. I've got 2 questions really and a comment. I've been involved in continuing healthcare a lot during my working life, and also been at the other end of it because I've, over the last 2 years, been working as a carer for 2 people who, in fact, both were in need of continuing healthcare. For me, I've got to say that the service is a service that's absolutely vital to the work that we do. And timely reviews and timely assessments are very important. My 2 questions are one about the money and one about staffing. If you speed up your assessments, especially in the community, doesn't this mean that you may well have to spend more on continuing healthcare because people are going to get into the system faster? And my second question's on staffing. I'm a little concerned that if we do pull continuing healthcare from people, it's sometimes very difficult for them to get the carers that they need. But mainly I'm concerned about our staffing. The paper mentions somewhere that we've looked at, or we were going to look at roles and skills of people. I just wanted some assurance really that we have looked at that and we are actually buying in the type of staff that we really need to keep the service going.
Karen, would you like me to take the first question about the money?
Please, Andrew. Yes, thank you.
So Pam, yes, you're right. The quicker we make people, essentially, the quicker we make people eligible, the more money potentially the CCG will have to pay. However, the caveat to that is, generally from that referral date is the date that the CCG would become responsible for that person's care should they become eligible. And actually, it does create a further admin burden if a long period has passed between the referral date and then the eligibility date, because we would then have to backdate that funding and either ensure that the patient has been returned to their status quo, or fund the council or whoever's been funding the care in the interim. So we have to then we always will make right that financial position. Just in terms of putting the staff in and the other benefits it would have, I firmly believe if we are able to do our reviews in a timely manner, then we will not be paying for patients that shouldn't be any longer eligible for continuing healthcare. So actually that would be a financial saving to the CCG. So at the moment, when we're not reviewing, we're potentially leaving people on a package of care that either should have that package of care stepped down to a lower cost package, or actually be taken off continuing healthcare entirely because it's no longer appropriate and things. So I think the benefits of having those timely reviews far outweigh the impact of making sure that everyone's assessed on time.
Thank you, Andrew. Thank you. So yes, Pam, absolutely. Everything that Andrew said is absolutely correct. And I suppose that the other thing around spending more in relation to assessing people in a timely manner is that if we can review, what we find is that we rarely find that people are no longer eligible. There are a small proportion of people that might need to be reassessed and taken off of continuing care, but generally people reach eligibility when they're at a stage in their life where their health needs are obviously complex and unpredictable, and it's unlikely that people become not eligible very often. But what we can do when we review is that we can make sure that they've got the right package of care that's reasonable and appropriate and meets their needs, and it also gives us opportunities to negotiate with those providers to make sure that the costs are right. So quite often when we review packages, we'll find that we can change the costs of the package without actually changing the actual delivery amount of care that someone receives, if you know what I mean. In relation to your question about staffing and roles and responsibilities, we have done a lot of work in Cheshire to understand the functions of the service and what roles are required. So we've got 58% of our staffing are clinical staff. At the moment, they are all nursing staff. We have changed all our job descriptions to include any allied health professionals. So occupational therapists, physios, dietitians, etc. are all welcome to join our team as commissioning practitioners, and we will do some more work in the new year to make sure that our adverts perhaps reach a wider audience, because so far those changes to the job descriptions and adverts haven't resulted any different allied health professionals joining the team. We have also made sure that we look at operational roles. So we've got 12% of our staff are operational staff. And so they're things like staff roles such as contracts team and performance team, project managers, etc., that help us to deliver the service without paying clinicians to do so. And also staff that are better skilled, have a different and more diverse range of skills than having a purely clinical workforce would deliver. We've also got 30% of our admin staff, and as I said before, they're essential in making sure that everything runs smoothly and that packages are paid, invoices are sorted, packages are loaded onto our systems appropriately. So yes, we will continue to absolutely continue to look at roles and responsibilities going forward as well. And we're also working closely with NHS England at the moment to consider apprenticeships. So that may well be that something of the future that we're able to look at further roles and responsibilities that others will be able to pick up rather than purely health professional staff.
Thank you, Karen. You mentioned something there which I think Suzanne was going to come in, so I'll bring Suzanne in now if I may, because I think there was just a question for Suzanne about something you just mentioned.
Thank you. Yeah, you just touched on it then, Karen. I just looked at the staffing ratio and I thought 30% admin seemed really high, and I was trying to understand from the paper, I appreciate it's very detailed, as to what that role was they were doing. Whether it's supporting the clinical side so they don't have to do some of the admin bureaucracy, or it just get a feel, because it did seem a really high proportion just to be behind the scenes, and I just wondered how that was actually working in reality on the ground and why it was so high.
Thanks, Suzanne. It is a really heavy administrative service, and we really do rely on our administrators to arrange all of those, you know, thousands of assessments and reviews that are completed each year. So, for example, they will gather the assessment material from professionals. So, if a patient is being assessed regarding their eligibility for continuing healthcare, our administrators will approach the GP, the hospital teams, and any other allied health professionals and social care staff that are involved with that patient to gather assessment information to be able to complete that comprehensive assessment appropriately. They also then arrange and set up the meeting virtually on Teams, make sure that the patient and family have access, etc. Send letters out to confirm appointments, etc., confirm reviews, then set up those reviews and make sure again that people have got the support they need in the background to be able to join virtual meetings or even face-to-face meetings going into people's own homes or care homes. There was also a lot of work to make sure that activities recorded on Broadcare, which is a patient ID system, and that helps us to generate all of the reports and monitor the activity that we need to do, so that we can return, put the Department of Health returns into NHS England, and we can track spend, understand when reviews are due, who our patients are, where they're up to in that journey, etc. So it is a very intensive administrative service. And we aim to, although it's 30%, we aim to make sure that then leaves the clinicians to actually focus on the clinical activity and to complete those face-to-face assessments and reviews and case management for patients.
Thanks, Karen. If I may, Chair, can I just ask, is there any efficiency IT system savings then that we could put in place there? Because it sounds very manual intensive as a process, that we need 30% of the staff to be doing the admin side. I'm just wondering, are there plans to look at to improve the way that process works so it's less intensive from a manual person intervention all the time?
Absolutely, Suzanne. We have digitalised the patient pathway a lot already. We've got digital referral systems into a single point of access now, and people can refer in using a digital checklist. Our staff, when they complete an assessment for continuing care, use a digital decision support tool that's a mandatory tool set by the Department of Health that captures a person's health and social care needs in a set manner to be presented for a decision to be made. We're also continuing to work with a development partner at the moment to extend that digitalisation to an end-to-end system. So that at the moment includes our decision making. So cases come through virtual on a digital system to have decisions made regarding eligibility. And we've also just recently set up and are piloting a patient portal so that patients can then log in and see where they're up to in their patient journey and assessment and when their reviews are due, or make contact with their case manager, etc. So there is ongoing work that we will continue to do to further digitalise processes and make sure that systems really work for us. Absolutely, and large parts are already in place, certainly.
Thanks, Karen.
So yes, thank you, Karen. Can I bring in Claire? And Claire, could you also, because I think this might be on some people's minds, we're about to potentially make a £1 million commitment. We are only existing until March. So can you just comment on the legacy position and how this and what we need to be thinking about that? So Claire, please.
Yeah, that was going to be one of my points actually. Thank you, Andrew. So first of all, thank you very much for the paper, Karen, Andrew and colleagues, to assure the governing body. This has had a really good run through at exec team at least twice, and I think at SLT and PDG. So I think Karen and Andrew have been put through the ringer in terms of challenges, drafts, redrafts, and thanks to Paula for her sort of support and leadership in this. And I just wanted to, just before I started, just to remind you all, just if you look at 4.1 in terms of service expansion, it does really show the enormity of what the team covers. I think it's worth recognising that, and as Paula said at the beginning, I think she said earlier as well, in terms of this being a frontline service, this is absolutely, you know, if our providers were putting business cases through for increased nursing and integrated teams in their organisations, the focus would be on patient safety, which again Paula has raised on a number of items so far. So I think it's just having that context. So I'm very supportive of option 4. I think option 4 gives us an opportunity to sort of bed in new staff, review how the service works with our wider partners, because obviously this service will be very much a place-based service. There will be Cheshire and Merseyside coordination, but I think this is absolutely fundamental to how we work in place. So I do think that phased approach is really important, so we can recruit, see how it works as part of the integrated team in place, and see what opportunities there are for doing things differently. And I think that option gives us the best way forward for that. In terms of the future, I think that we need to, and Linda will need to do this, build this in to any 22-23 finances. I mean, we've been clear that across Cheshire and Merseyside, we need to think about how we pause recruitment other than business critical. I would recommend this is business critical, both in terms of our performance and the patient care. You know, we're not, with this, you can see the delays, you can see people waiting. Reputationally, I'm worried to a point, but I'm less worried about our reputation as opposed to the patient care that we need to give these vulnerable people. So I will speak to, and myself and Linda will take this through into the discussions at Cheshire and Merseyside in terms of business critical recruitment. It will have to be part of that successor organisation, but as Paul has said, it fits with the Cheshire and Merseyside approach. It's not out with that, and you can see the benchmarking. We have a large number of people on our books, and we don't have the same staff to patient ratio. So I think we can easily explain, justify if we need to. I'm comfortable to recommend this to governing body, but also up to the ICB. And if necessary, we'll take those discussions forward. But I think it's very much, I think the phased approach gives us an opportunity to learn as we go along. And we have got that flex to change our approach as we go into 22-23. So it'd be up to the maximum in a phased approach.
Thank you, Kate. That's a helpful steer. I've got 2 more questions, and then we'll move to the conclusions because we are slightly behind. We'll be slightly behind time by then. So I've got Dr. McKelvey and then Dr. McGregor-Smith. So Dr. McKelvey first, please.
Thanks, Andy. Claire's actually mentioned a couple of the points. Really, I just wanted to give some oversight. I've provided some clinical steer to support the paper, and frankly, there's some questions that I'd ask myself are, you know, it is an exemplary service. I remember the service some 7 years ago in a critical state, and actually what's happened through the stewardship and leadership, we've got an exemplary service. It's under-resourced, but it is, as stated in the paper, one that actually meets a competency framework and has been well supported by NHS England in this respect. My question is the time right now? And as Claire's actually just mentioned, this is absolutely business critical. So it's not a standalone service that needs some support. It's absolutely part of other strands of our service and support other providers, really. So I really, you know, is it the right time to invest? Absolutely, it's the right time to invest, and it's going to support, or, you know, especially for those patients and those families, but also the wider providers and our urgent care system. So I just wanted to make that point, which Claire alluded to. Thanks, Andy.
Thank you very much. Can I go to Fiona, and then we'll ask for.
So hi, thank you. So my questions are around page 13 or page 61 of our report, which is to do with the graph and 3.4. I also had queried about the legacy of this, but I think Claire mentioned that quite a lot. So, I mean, I appreciate that the y-axis of the graph starts at 3200 and not at 0, but the trajectory is steep. And also, if you look at the table of 3.4 below, it suggests that actually the number of individuals have gone down a bit, but the cost has still gone up. So my question is, are we presuming the trajectory will continue to rise like this? Has the actual number of individuals per 50,000 gone down because their conditions are getting more complicated? In which case, will the trajectory get steeper yet? And does that impact on what we should be investing now and our legacy investments going forward, that what we're going to be asking ICB and ICSs to take on with? And so that is quite, I suppose it's a financial question really, but also you commented on, and I think this was very helpful, the staff and retaining the staff, and we've had a look at that already in other papers today. Staff experience is absolutely essential. The people who will be doing the work need to not to feel overwhelmed by their work, because that's how we lose them. So we need to make sure that we actually have adequate staff doing what is undoubtedly a very difficult job, so that they can do it properly. Then they'll stay, then the patients will get the right care, and the whole thing will be much better. And so I'm very anxious that we should be having the right number of staff actually doing the work.
Thank you. Excellent points. Fiona, can I just go back to Karen? Then we've got one point of clarification from Peter.
Thank you, Fiona. In relation to the caseload and the graphs that you alluded to in section 3.3 and 3.4, yes, you're right, the caseload is rising. What we actually see is that the numbers of people that are eligible for standard continuing healthcare funding is actually quite static. And we know that our eligibility rates are in line with the national average of the number of people that we assess and then find eligible. So that in itself is rising, but rising very slowly. The actual sharp increase is in the number of people that are fast-tracked to continuing healthcare funding. And so that's people that are at the end of their life and thought to be in the last sort of 3 months of life requiring an urgent package of care to help them to die in their preferred place, generally at home. We've seen a really sharp increase in those numbers since the resuming of work post-COVID, and most of those significant numbers are coming out of hospitals. So we are looking at the referral processes in relation to fast-track referral, and the additional resource will also allow us to then review those individuals to make sure that A, they're getting the right care that they need, but also that are they actually eligible, because I think sometimes when people are discharged from hospital, acute services perhaps put in more care or refer people for fast track when actually a standard assessment process may have been more appropriate. So there is work to do in relation to reviewing those individuals and looking at that caseload size. Yes, certainly.
And just to comment on the fast tracks, Fiona, around about 12 months ago, we were spending around £2.5 million on fast tracks. We're spending over £10 million, or forecast to spend over £10 million this year. So that just shows the rapid increase in the number of fast tracks we've had to fund this year.
Thank you.
Sorry, can I just come back, Chair? A question. This may be completely not relevant at all, but or not possible. But do you think that some of the fast track referrals are made as a result of COVID, because either the acute hospitals are wanting to actually discharge people quicker, either with or without COVID, but to try and get them out? In which case, is there a case to be made for assessing COVID mummies from somewhere?
Generally, they're not patients with COVID that are being fast-tracked and discharged, Fiona, although it certainly might account for some of them. But I think there is a desire for hospitals, given the pressures that acute trusts are facing at the moment, to speedily discharge people. And as a CCG, we can't refuse a fast-track application. So I think our job is to make sure that the right people are fast tracked and that they get the right care that's appropriate to them, and that we actually feed back to referrers when an alternative pathway such as a standard assessment process might have been more appropriate, and also reviewing those people at 3 months to just to ensure that they are eligible and getting the right care is really important.
Yeah.
Claire is desperate to come in. Claire?
No, it was just to say, I suppose that's why it's so important that this is part of an integrated place working, because at the moment, budgets are such that, you know, this is health, this is CCG, this is local authority, this is, and actually, if you start owning each other's budgets and owning the responsibilities, you might have a sort of way of working change, and that's why it's absolutely critical that this is integrated. You know, it's part of the urgent care, it's part of discharge, it's part of flow, and obviously it's in terms of good patient care. But I do think by having this intrinsically in place with other providers, they have to own it, and by fast tracking it, the costs have gone up that, you know, that exponentially. We're not spending money on other things, we might be spending it inappropriately, and that's where we need to have those integrated budget and service decisions and discussions.
And Claire, that's also on the back of having the hospital discharge programme as well, which has supported discharge from hospital. So without that, like I say, it may have encouraged the referrals into fast track, but because we've had that in place, it will have compensated some of that. So actually, the fast track spend, I think, is real.
Thank you. Can we go to Peter, your point of clarification, please?
Yeah, I've been waiting for ages as well. But,
Sorry, Peter.
I'm not going to question the principle of the investment at all. Just the timing. Against option 3, you've identified about £250,000 worth of 21-22 spend, and against option 4, it says go and look at Appendix 4, which I've done, and there's significant spend in there for January and April, and I'm confused as to whether we're spending anything at all in 21-22. If we are, and this is probably more for Linda, is this reflected in the H2 position or the H2 forecast?
Linda, can you answer that?
Oh, I can answer. I can talk about the funding. So Peter, the Appendix 4 or the schedule in Appendix 4 January would be January 2022, and from that date that would make that funding available to begin recruitment. Now clearly, we aren't going to spend. We're not going to be able to spend that whole amount of money in that first quarter, because obviously recruitment takes time. It would potentially allow Karen to perhaps use some of that funding to fund any pressures like non-recurrently through agency or such like. But yeah, so I think the idea of the phased approach, it would give sort of access for Karen and her team to begin recruitment. Recruiting that number of staff won't be easy, as Karen's alluded to, with it through the care market. So it will take time to get good quality staff in, and hence that's why the phased approach might work better for the team, rather than have the pressure of trying to recruit 10 nurses all at once. You may lose the high quality candidates that we sort of only employ currently. So there will be that element of funding available from January onwards, and April onwards and June onwards. But obviously recruitment would have to come and support that funding. So there would be a small amount of funding required in 21-22. No, that's not currently accounted for in Linda's H2 position, because obviously we haven't made the decision to fund that as yet.
But I think, can I just come in, Andrew, please? But I think, Andrew, in terms of the funding being available in June, September, that is subject to continual review and checkpoints. And I think we would have to build in those checkpoints both at a C&M level and at a place level. So it's only ever going to be up to, and we might make a collective decision in place to pause or to stop completely with C&M. So I think this gives us some flex, but I wouldn't want everyone to assume the recruitment absolutely, it's not full. We're not saying if we agree with option 4, it is not full steam ahead. It is a phased, pause, checkpointed approach. So we have to give that assurance up to CNM and back into place.
Yes, of course. Sorry, Claire. Yes, of course.
We have to know, I think, bearing in mind we were talking about an £8.7 million QIP target earlier on, we have to know how much, what the potential liability is in the final quarter of the year.
And we also need to know, Peter, if we've talked in the paper, the return on investment, if we're going to invest a quarter's worth of funding, are we going to get £500,000 back? Because that's the paper I remember, it's not in front, but it's sort of, you invest £1 million, you get 2.4 back. So actually it's sort of if we're going to invest 200,000.
Can anybody answer that question? You may not be able to do on the hoof, but can anybody that can answer that question in terms of what is the investment in the first quarter in the year we're looking at, and what is the likely return on investment in that quarter? You may not be able to do so. Yeah, go on. I think Andrew and Karen.
That's what the paper says. We can't wait till full investment to get any return. It's not £500,000 return on £1 million. It's £2 million return on £1 million. So,
Andrew, I can't give you the figures. I'd leave that to Andrew Whittingham to answer, but I can assure you that I know from past experience and past QIP schemes that when we start being able to review people and to negotiate with providers the cost of care and the package of care that people actually require and need, that we make significant savings. So I absolutely know that the additional resource will return on investment. Not only will it make people's packages of care safer and more effective, but it will return on the investment. And like Claire says, we will make sure that there's an implementation plan that monitors and stops and pauses to look at where we're getting to with additional staff and what's next, etc., so that we plan that progress up to the number of staff approved.
So, would it be fair to say then, and it'd be probably for Karen and Andrew to probably put this one to sleep a bit, that if an extra member of staff were employed and they cost £50,000, that we would expect possibly £100,000 worth of savings to come fairly quickly through employment of that member of staff? Is that?
I would say that's a really good assessment. A £2 return for every pound spent, I think would be, would certainly fit in with our QIP projections that Karen alluded to earlier. Just to answer Peter's point, I have got a looked and added the two numbers up. So it would make funding available up to 444,000 from January onwards. But obviously, again, back to the points before about recruiting those staff, and again back to Dr. Wilson's point around that actually as soon as we get a nurse in, that we're able to then put them on to doing the reviews, and actually that will then return a cost saving back to the CCG in terms of looking at those packages of care and getting those reviews done and things. So actually, I think overall, it will be an invest to save scheme ultimately.
I'm being very selfish here, but all I'm thinking about is the 21-22 position and the fact we're potentially adding costs and potentially getting benefits back, but I've not been told either figure. So if the benefits come in the second quarter, if the benefits come in start coming in April, that's no good to Cheshire CCG. What we're doing is adding to an £8.7 million target.
So I suppose if I can, we're going to need to move. I think you're quite right. You're quite right, Peter. It's an important consideration for us. But I think what I've heard overall from the feeling from the governing body is that the majority of the savings, the considerations for this would be in terms of an improvement in quality and timeliness of assessments, a reduction in risk, and that yes, that there is an investment and potentially some of that is this year, but I'm hearing that actually there's going to be a fairly quick return on investment, which has a multiplier on it that mitigates that. And yes, we might be in the unfortunate situation that some of that money falls in this financial year and some of the benefits falls in the next financial year. but that might be, I suppose, overridden by the larger overall benefits to the people that are getting assessments. Right, shall we move to actually seeing where we are with agreeing our positions? So we're asked to note the performance delivery capacity for NHS community and healthcare, consider the gaps in service and options that are addressed, and we're asked to endorse the recommendation, endorse or approve the recommendation, which is option 4. Having heard all of our discussion and take into account everything that has been said, including Peter's points about the increase to our potential financial position and possible mitigations with return on investment, but they might fall in the wrong place and they may not come up quite at the same time. Where is the governing body feeling in terms of that? Are we minded to agree the recommendation, which is option 4? Does anybody feel that we're not in a position to agree option 4 and that we need to do any further work or anything different?
Andrew,
Yeah.
I think I'm.
Okay, so I think nobody's in disagreement. So I think everybody is in agreement with option 4, as far as I can tell.
Sorry, sorry, Andrew. There is a small compromise, which is to say that we expect equal and opposite savings to the investment in the final quarter of the year. That's got to be the target.
Absolutely, I think that's what the team are suggesting. That is their expectation. I suppose the problem is they can't give a guarantee of that. That's probably the difficulty, isn't it? Well, the decision then is what we're going with.
I'd be happy with the endeavour to do that. You know?
Yeah.
You have my assurance, Peter, that we will make as many savings as we possibly can, and we have always over exceeded our QIP targets in previous years, and we will seek to do so again. Absolutely. My number one priority is to make sure that people get safe and effective care. Absolutely. But I know that by doing that and doing it properly, we will make a return on this investment, and I completely assure you that that is absolutely possible. We'll also make sure that it's a QIP programme for next year so that the savings can be tracked appropriately and fed back to governing body.
And we have an offer from Christine Morris to be a critical friend on behalf of the governing body on this. She has, as we know, some not inconsiderable experience in the area. Yeah. Okay. So,
Andrew, sorry, I think absolutely agree, but I think there's just that. Linda and I need to take this to Cheshire and Merseyside just to absolutely get that sort of confirmation, which I think we agree it today, and we'll just work with Cheshire and Merseyside, I think, to manage this through into the new financial year.
Okay, we'll be making a decision. So if Cheshire and Merseyside disagree with us, then we'll have to consider whether we wish to unmake our decision, won't we? But we'll make a decision now. So, okay, so and I think we are in that position. I think we are agreeing, unless anybody sticks their hands up. They haven't. Good. We're confirming then that we are endorsing or approving recommendation number 4. So thank you to Karen and to Andrew and to Paula for presenting that to us. I think it's important that work does go ahead. But I think you've heard the caveats that we have around the financial position for the CCG.
Thank you all very much. Thank you. Bye-bye.
Well done. Thank you.
Right, guys, we are a bit behind now, but we are on to 4.3. And it is the item you've all been waiting for. It is the revision of the CCG schemes of reservation and delegation. It's on page 83 of your pack and will be ably and entertainingly delivered by Matthew.
Thank you, Andrew. You always give me a good big up before these items, so thank you very much. So Matthew Cunningham, Director of Governance and Corporate Development. Because of time, I will try to canter through this paper as well as the next one as well, Andrew, as well. So hopefully you've all had a chance to review what has been an extensive piece of work done by Phil, Dylan, Alex, and thank you also to Suzanne on the call, who's offered us some counsel on this before we brought it to governing body. So we've alluded to a lot of this already in our previous conversations. Because the governing body has recently agreed around delegating authority to both our 2 place committees and recently our joint committee, we've had to make some required amendments to our scheme reservation and delegation and our standing financial instructions. Hopefully, by reading through the paper, you've seen how it's clearly articulated what it is we've had to do, both in terms of the sword, in terms of including the new committees in and taking some out, as well as, in effect, the new lines that we've had to put in our standing financial instructions. I think the key things that the paper tries to highlight to you more than anything else is that a bit of clarity around what the financial authority is for these committees, and what they can make decisions on, which in terms is unlimited when it's money that's coming from a specified pot, for example, externally, or what's within the limit as signed off by the financial plan that we've just discussed, for example, and within our commissioning budget. And those decisions that come to us where there's a financial ask that's outside of what's already been agreed within our budget and our sort of financial plan, then the proposal there is that that committee, by virtue of the authority of the executive officers in attendance, and we've given Claire as an example there, has the authority to make financial decisions up to that amount. So as an example, we've highlighted Claire has that 250,000 and up to 500,000 for COVID related decisions. Anything above that, of course, we need to seek the approval of the governing body, which in terms of the process could be done before or after one of the place committees or the joint committee. So hopefully the paper is clear. Hopefully the appendices are clear as well. It is relevant to a conversation later on in agenda 5.2 as well, where we're talking about the place committees. So please keep that in mind when we do get to that item as well. And Andrew, I'll leave it at that and take any questions.
Thank you very much, Matthew. Very important that we get this right. We're in a sort of a complex governance world at the moment with the power things, so it is really important this is correct. Are there any questions for Matthew on the changes to the scheme of reservation and delegation?
I like silence, Andrew, that's good.
Yeah, I think we've got no questions. So I think we can just move then to the recommendation, which is that we approve those revisions to the CCG scheme of reservation and delegation to reflect, and you can all read what it says to reflect, and Matthew has just been through them. So I'm looking at your faces and looking for approval or a nod, and I've seen approval. I'm not seeing anybody disapproves. Thank you very much. We agree though. Thank you, Matthew. Item 4.4, which is the governing body assurance framework, and once again to you, please, Matthew.
Thank you. So just in terms of the previous item, just to confirm, in terms of next steps, we'll make those changes official and publish them on our website and our governance corporate manual. So on to the next paper. So this is the Q3 update in terms of the governing body assurance framework. Again, a big thank you to Phil Meakin and many others who are the risk leads to keep this up to date, on top of all the other challenges that we're facing as well. Hopefully you'll see it's a very comprehensive paper, and it's a bit more this time because we've got a bit of a spotlight on our risk around the environment as well, which I'll get onto in a second. But hopefully from reading the report you will see, you'll receive the assurance around what's going on in terms of making sure we're keeping our risks up to date, what our mitigations are, and really the assurance processes around that, especially as we've just discussed, all the things that are going on in terms of our internal committees and the other committees that we're now part of externally. So hopefully you'll see from the report, and especially table 2, which is on page 158 to 159, what's being proposed in terms of increases to 2 of our risks and a reduction in the risk score of at least 1, whereas 8 stay the same. So the 2 that we're proposing are increases in risks are our risk around 2102, which is around our ability to work effectively with our partners, 2106, which is in terms of risks around staff, and the reduction is in relation to clinical leadership. So we're asking for an increase in terms of our effectiveness of working with our partners. It's an increase our score to 12 from 9. In terms of the risk around our staff, it's an increase from 12 to 16. And in terms of the reduction, in terms of our clinical leadership, it's from 12 to 8. Table 4 in the report provides you that kind of snapshot of the reasons why we're suggesting these changes, as well as why the other 8 are staying the same. And Appendix 4 gives you that greater detail if you want to get into that. And again, thank you for many of you who've provided that detail to help us to get to today as well. Like I said, this report also gives the governing body a focused spotlight on our risk around 2101, which is our environmental change and what we've been doing in terms of our commitments around the climate change and our action plan. Hopefully you'll see, you've had a chance to read the report. That's in Appendix B, that gives you that update on where we're progressing. I'm sure Dr. Rees might wish to add something more to that as well. But I also want you to, hopefully take from that report and really note that despite all the pressures that we're under, we still continue to give this the priority it deserves, both as the NHS and our partners. And hopefully you're pleased to see the progress that we've been able to do during this time as well. Finally, Andrew, you'll see on page 156 a bit of an update in terms of the operational risks. So you'll see in Appendix C our top operational risks, but also a bit of a short update on what's going on in terms of our Cheshire Merseyside region around the transfer of risks going forward. We are still waiting for a little bit of national guidance around that sort of transfer of risks. That's not stopping us working together as 9 CCGs along with Mersey Internal Audit Agency to look at what needs to be done. And as Claire talked about before, it's all part of a piece of work that we're doing in terms of close down as well as a CCG. So I will leave at that. No doubt I've got a couple of questions around some of the risks and happy to answer them.
Thank you very much. Just looking to see who's okay. I think Peter, you're first. And my apologies, Peter. I think I missed you out before. Are you not first now? Am I now putting you in when you don't want to get in and ignoring you when you want to speak?
Well, actually, I shouldn't complain, but you ignored me the first time round in the on the previous item, and
yeah,
that was coming in to tell you that. So I've got no comments on this. Good piece of work, and on 21.02, very timely. I think that increase in risk, considering what's been going on. Somebody must have a crystal ball. So.
Yes, my apologies, Peter, for missing you.
Not at all.
I had missed you. I think Christine Morris just wants to come in.
Thank you. Thanks, Matthew. Great piece of work in pulling this together. Just picking up on the points that Claire made earlier in her AO's report around increase in sickness absence related to anxiety and depression. I'm pleased to see that the risk has increased because that puts it to the forefront of our thinking. But I just wanted to ask you, are you confident that the mitigated actions that are detailed in the 2106 risk are supportive enough of our workforce and their ongoing well-being, or are we likely to see pressure on a remaining staff as recruitment changes, which we're hearing through evidence like the Pulse survey? So are we doing enough basically to support the well-being of the staff that we have within the organisation at this time?
So thank you, Christine. So I'll attempt to give an answer to that, but recognising that there's a lot that's in scope of the CCG that we can do, and then there's a lot that's clearly external to the CCG that impacts on our staff stress and anxiety. So we, as a CCG, and as you've had previous updates around the people plan, what we're trying to do to provide support, and that's caveated with pretty much what Claire said at the beginning. This has been a virtual organisation for 2 years, so a lot of traditional stuff you might have considered an organisation to be able to do, be it face-to-face, hasn't been possible. What we have seen and what we've taken advantage of, especially over the last year, there's been an absolute wealth of resources available to staff to access to help them with resilience and well-being, as well as support. And then you marry that up with people's opportunities. So we've talked quite frequently around the organisational development, prospectus and all these other things. So we've tried to support as much as we can, both from when people are either at crisis and therefore they've got access to occupational health or counselling, or support around their workload, but also how to deal with work whilst working from home. It's a frequent message that we do as executive team at our team briefs to try and support our staff, and we empower our leadership team underneath to do that as well. We've implemented our wellbeing conversations and the training behind that as well, and we're working very closely with our partners and the Integrated Care Board going forward in terms of what does this mean for our staff. And I'm sure Claire will talk about, she's got time, and she has done previously, around the Cheshire Merseyside Workforce Group and the OD Group, and staff wellbeing resilience is a #1 priority in all of this, especially as we're going. Can we do more? Absolutely, and I think that's the point, really. We've got to see what comes out. We have to respond to what our staff are telling us, and we have done in terms of what's come through the Pulse survey or the NHS staff survey. And we try to, make bespoke sort of courses and training for them. And I know you're aware that Karen Sharrocks, who's our sort of head of corporate development, has been doing some really focused sessions on resilience, along with our support from our external providers. So I'm confident we're doing as much as we can as a CCG, but we're not resting on our laurels, and we'll continue to offer more where we can. And it's definitely one of the key legacies we want to give to the ICB, is this massive focus on supporting our staff. And I think we're pushing against an open door, with our colleagues there. So I'll quite open up to anybody else, and I'm sure Claire might want to answer some of that as well. She might not. I don't know.
Yeah. Thank you. I think we are blessed with a very engaged and articulate workforce who've been through a lot of change. So, as I said, at the beginning, have gone through quite a big change cycle with changes in leadership. Then, merger 4 into 1. Other CCGs haven't done that, so there'll be different levels of stress and anxiety around the establishment of the ICB. But I think there is something also, everyone's worked virtually since the beginning. So we went from the merger into virtual, and interestingly, we've still got the 3 bases, haven't we? So we've never really had a corporate sort of single place. We sort of aspired to that. So when you go into the office at the moment, there might be a few in one office, but there'll be a few over here and a few over there in the other bases. So it is that sort of, working together. It's the coffee breaks, it's the water cooler, it's the, you're walking out out to the car. We are doing what we can. I know our staff would like us to do more, but it's that balance between, sort of giving support to staff, but asking them what support they need. So, absolutely, Chris, we want to do more, and you can see the figures. I think we just need to be at that sort of caution in the figures, that there is a balance between home life, work life stress, what are the home stresses that come into work, and vice versa. But obviously we sort of record them as work related stress. So, our staff have been fantastic. I've said that, we're always saying that. So we want to do all we can to support them, particularly through the next few weeks and months and into transition. And as Matthew says, one of our legacies that we're all really proud of is that support and that OD work. So we take that both into place and into CNM.
Thank you. Christine, does that give you the reassurances? Very well.
Yes, thank you. I'm pleased to hear that.
Lovely, thank you. Fiona, do you want to go in and articulate your question, please?
Thank you, Matthew. I promise I did read all of this, but so it's a overarching question. It's what happens to the risks that we would expect to be taken forward, like the climate risk, like the staff risk, probably, which could possibly be less prioritised as we move into a much bigger organisation. Is there any way that we have of making sure that the things that we've identified of key risks actually stay that? You did mention it very briefly as I was typing, but I just wonder if we could have a bit more detail about that.
No, absolutely. It's a really good question, and one that we're asking as well. So I'd probably say, firstly, as a CCG, because we've recently refreshed our strategic risks, they are truly quite encompassing strategic risks. So I don't think any of them would necessarily be lost or deprioritised, because pretty much all our risks are all really important ones. But there is that piece of work that is ongoing and still needs to be finished in terms of, so what are the other 8 CCG's risks, and how will those risks be incorporated into the ICB, or what will go down to place, or other arrangements as well. So I can't articulate yet what that will look like, and that's the part of work that Mersey Internal Audit Agency are supporting us to do as well. and it will need to come back to governing bodies and joint committee to give that kind of assurance. But again, that kind of legacy of risk, both operational and strategic, is part of that kind of work stream to make sure that just because of a structural change from the 1st of April, the risks aren't lost, because the risks are still there. So again, I think that's part of what we've tried to highlight in the paper about what we wanted to keep taking to the Governance and Audit Committee, so they've got that oversight and understanding of what it is. So from an assurance point of view, to use a governing body, you know, our committee is keeping an eye on those sorts of things, and it's up for me and my colleagues across Cheshire Merseyside, along with Mersey Internal Agency, to bring you back that detail, which we will in the new year.
Thank you very much. So can I bring in the last comment, which will be from Dr. McKelvey, and we are short of time, Andy, so you can be delightfully succinct as you always are.
Thank you, Chair. I just wanted to comment on the clinical leadership one, to be perfectly honest with you, because I have, there's a downtick to 8 from 12, so I thought it appropriate to me to make a comment. We did have, Sinead and I did have a healthy discussion with Mr. Phil Meakin and Mr. Matthew Cunningham regarding this risk. But I thought we're living in a bizarre world, and it's actually bizarrely sometimes helped clinical relationships, helped connections across a wide piece, which is Cheshire. So we just thought, Sinead and I, why don't we reduce the risk? Because analysing what we're doing and analysing the governing body GPs and their roles, analysing the connections we got with practices on a weekly basis, we thought that actually when you interrogate this, and things have happened, it doesn't stop things happening, but when things do happen, such as difficulties with EPR implementation in certain areas, we've had lots of feedback, we've had lots of clinical connections. And so we thought actually it's a pretty mobile organisation that we've got, and a flexible organisation when it comes to communication, despite the obvious difficulties that we've got meeting in this format. So we just threw out there, it's a challenge. It might go up to 12 next month if you all disagree, but actually we're quite comfortable with it, but not complacent.
So I think, Andrew, you know, we can't be complacent on any of them, and I appreciate, you know, that the clinical leadership risk is a challenge that is faced with the environment that we are as well. So as always, there might be a change for the Q4 updates, but that doesn't stop us looking at it until that time as well. But you know, thank you for your comments.
Thank you, colleagues. Losing my word, colleagues, for your important comments on that. I think we can move to the recommendations, unless there is anything more for anybody to input. We're asked to review, approve the changes, and to note the progress which has been made on both the GBAF and the operational risks. Are we in agreement with that? Thank you. I believe I've got enough nods there, so we'll approve those. That moves us on to our last few items, which are all reports. And so let's go to 5.1, which is the report of the Joint Committee of the Cheshire and Merseyside CCGs on page 237 of your pack. It's you're asked to note the report. It's for me to introduce to you. I don't intend to speak to it. You've had the opportunity to read it. We're in the position, aren't we, where the Joint Committee, our place committees are important in our governance and the way in which we use these as mechanisms to get assurance. So they are very important, but I don't intend that I go through it by item. But are there any questions or comments on that report? No. Okay. Thank you. So I think we can note that. We can move then to item 5.2, which is the report of the chair of the CCG place committees. And we had one in East and one in West. I chaired the one in East, but Goodwin chaired the one in West. So I'm sure Goodwin will be in agreement with me that we take questions on those reports if anybody has any. Well, I know we've got a ratification, Matthew.
No, I'm just conscious that in terms of the West one part of the item was chaired by Pam because of the conflicts faced by GPs present on the day, and we have GPs present today. and the governing body who would be wise to express conflict of interest for this particular item as well, even though we are asking for a ratification.
Yeah, absolutely. And in fact, what I'll do is we'll take the item on noting the report, and I'll actually pass it to Pam, if I may, to make any comments that there might be about that section, that ratification, and to ask for the governing body to ratify that section so that I'm not conflicted in that.
Thank you for that. I don't think I've got any comments.
Can I just take the first bit first though, Pam? Is it, are we happy to note the report? Both of them? Yeah, okay. Thanks. Yeah, go. Off you go then, Pam, sorry.
I don't think I've got any comments to make on the report because it's actually quite self-explanatory. So I just say if anybody's got any questions, I'm quite happy to take them. Otherwise, can we go ahead and ratify that item, please? No questions? Great. So we can agree that.
No, I have a question. Sorry.
Yeah, I've got a question.
Fiona, before you speak, just remember you're in a conflicted position, so that's why we're not involved. So just bear that in mind before you ask whatever you're asking.
Right, no, so my question is, I might have got confused about which committee did what, because what I couldn't do is, we did discuss, I think, about the numbers that were to be provided by the secondary care providers for patients to contact them if they couldn't find, if they wanted to know where they were on waiting lists. I thought that was at the West Committee. Have I got that wrong? Everybody's looking blank. Was I at a different committee?
It was West, Fiona.
Yeah. Okay. So so while I'm conflicted in that, I'm a GP and I'd rather the patients phone the hospital directly than my staff. I haven't seen those. I raised it at the time and I haven't seen those numbers yet circulated, and I have asked and they haven't been done. So I just wondered if there was any update on that.
So I think Neil can, and I don't think you're conflicted on that bit, Fiona. The bit that you're conflicted on is the ratification of the additional funding going to the west part of the patch for social prescribing. So Neil, do you want to answer?
Yeah. In my inbox, and I know Sinead and Andy have also got it in their inbox, there is a draft communication to GPs about waiting lists. That should include, interestingly, the two hospitals in Cheshire East, not Cheshire West, Mid Cheshire and East Cheshire's phone number, because they hopefully both have them set up. I know East Cheshire certainly do, and I believe Mid Cheshire now do. Countess don't yet have that line set up. So that briefing to general practice will include that information, which hopefully will go in today's newsletter that goes out.
Thank you. May I have a follow-up to that, Chair, which is, are we expecting one from the Countess? And also, I thought CWP, who were represented at that meeting, because that would be very, very useful.
Yes, that's my understanding. I just am not aware they've actually got them. I certainly know Countess haven't yet got one live. I would need to confer with others around what status we are with CWP in terms of that phone line.
So do you mind if I continue to badger you about that for the next 2 or 3 weeks?
Feel free.
Thank you for that. So I think, in conclusion, we have noted both the reports, and under Pam's chairmanship of the ratification, we've ratified the decision on funding in West Cheshire. Yeah, thank you very much, and thank you, Pam, for stepping in there at short notice and without any notification. I think you did brilliant as always. We're on section 5.3. Which is the report of the Chair of the Governance and Audit and Risk Committee, which is on page 273. Peter, did you wish to say anything, or do you just want to take questions?
I'll just take questions.
Are there any questions for Peter on that report? Okay, I don't believe so. In which case, again, we are asked to note the report. Our last item is any formal business. I've not been notified of any business in advance, but is there anything anybody wishes to raise? No, in which case we can close the meeting with just a note to a reminder to governing body members I've been asked to give which is there is a 45-minute information and governance training session at 12:45. And with that, I can close the meeting at 12:30. I never thought we were going to get there at 12:30, but we have. Thank you for your time and consideration and your input. And I'll see you all in information governance training.
Thank you.